Good evening, everybody. I am Rahul Chobe from RHEUMAT TV. We are live now. I am handing over this session to Dr. Madhav Borate, sir.
Good evening, friends. It gives me great pleasure to welcome all of you to this webinar on All is Not Rheumatoid Arthritis. This webinar is with RHEUMAT TV as a part of our single rheumatologist and a professor.
Negative anti-CCP, negative ANA. She was diagnosed as rheumatoid arthritis seronegative, and she was initiated on hydroxychloroquine, mild dose of steroids, and NSAIDs. So on treatment, this patient developed a generalized rash. Initially, it was thought to be a drug allergy, and she was referred to me. So no doubt, patient had polyarthritis. She fit the diagnosis of rheumatoid arthritis and can be labeled as seronegative rheumatoid arthritis. But I felt it could be undifferentiated collagen tissue disorder, and she was put on methotrexate. But 1 week later, she had to be hospitalized in emergency department with severe proximal muscle weakness, neck flexor weakness, and shortness of breath. This was just 1 week after I had seen the patient. And of course, there was generalized rash, which had worsened. And it is then that I noticed she also had fissured skin on the digits, and she had history of Raynaud's. Her investigations revealed very high CPK. MRI thigh was done, which revealed myositis. And lucky for her, we had all these facilities, and we could do all the investigations. And she was diagnosed to have inflammatory myopathy, or dermatomyositis to be specific. She was pulsed with methylprednisolone. She did not respond to that, and decisions were quickly taken. She received rituximab. This was around 6 years ago, and she responded very well to the therapy then. And for over 4 to 5 years, she has been very stable on methotrexate, and she is off steroids. Only this year during this lockdown, she developed another flare and again received rituximab, and she is doing very well. So my second patient was not as lucky as the earlier one. She was 18 years female. She was receiving treatment for multiple joint pains for over 3 months with a primary care doctor. 2 months on treatment, she developed fever, loss of appetite, fatigue. She had chronic rhinitis and was not responding to oral antimicrobials, and she had to be hospitalized with worsening general condition. Her systemic symptoms persisted despite multiple IV antimicrobials, multiple evaluations, ENT evaluations, sinus drainage, etc., etc. But after again a few days of various other antimicrobials suspecting sepsis syndrome and all, rheumatology reference was sought for the diagnosis of rheumatoid arthritis with fever of unknown origin. Cutting the long story short, the patient was diagnosed as ANCA-associated vasculitis with pulmonary hemorrhage. She received pulse methylprednisolone. Since she was young, I would have preferred cyclophosphamide for rapid action, but she was young. She received rituximab. She responded and was discharged. In fact, when I had seen her, she was on ventilatory support. The response was very rapid. But unfortunately, within 7 days, she was re-hospitalized with severe pulmonary hemorrhage again. And she ultimately was almost at least a month's delay, we can say, and we lost this patient. So another patient I would like to, ultimately the patient was diagnosed to have SLE to start with, and she had glomerulonephritis class 4 diffuse mesenteroproliferative off steroids, but she is on mycophenolate mofetil. It's very important to consider few of the differentials and especially any extra-articular manifestations if these patients complain, even if rheumatoid factor might be positive. So there are almost more than 100 different diagnoses that the patients, if have, will present with multiple joint pains. So even if patient has multiple joint pains, evidence of peripheral synovitis, it is not synonymous with rheumatoid arthritis, though rheumatoid arthritis is the commonest disease. So what other conditions? Systemic connective disorders like SLE and all other connective tissue diseases like Sjogren's, scleroderma, mixed connective tissue disorder, inflammatory myopathies, then systemic vasculitis, seronegative spondyloarthritis, especially the infectious arthritis. We all are aware of chikungunya arthritis, which we are almost have everybody has seen. Even patients with osteoarthritis can present with polyarthritis or mechanical polyarticular pains. Then there are various conditions, metabolic causes, endocrine neoplastic causes, which can present with multiple joint pains. Even chronic pain syndromes like fibromyalgia needs to be considered. Hereditary connective tissue disorders might present with multiple joint pains. Now, this is the classification criteria for rheumatoid arthritis, which was put forth in 2010. And this was quite successful in identifying patients with early rheumatoid arthritis. And all the three cases which I showed by these criteria will be diagnosed as rheumatoid arthritis. But what we were missing is all the extra articular features which were pointing towards different systemic diseases. So just before labeling anybody with rheumatoid arthritis, even though they fulfill the criteria, one should consider the most common inflammatory joint diseases uh, that can present like rheumatoid arthritis. Psoriatic arthritis, in fact, is one of the most underdiagnosed condition. Almost 3% prevalence of psoriasis, and of those, around 8 to 30% patients might have arthritis. Okay. So, unfortunately, patients with psoriasis mostly are seen by dermatologists, and patients don't tell them that they also have joint pains. And if at all they have joint pains, they mostly consult orthopedicians, where they don't tell them that they have psoriasis, especially if patients have mild psoriasis. So it is very important to ask for history of psoriasis. Even family history of psoriasis is very important. If patient doesn't have first degree or second degree relatives have psoriasis, one has to strongly consider the possibility of psoriatic arthritis. Infectious arthritis, there are various viruses like Epstein-Barr virus, parvovirus, cytomegalovirus, all hepatitis viruses, HIV, and the more common chikungunya viruses, which can present with polyarthritis. The differential, probably one has to ask for history of fever and rash at onset of polyarthritis. If you don't ask, patients won't tell. And patients with chikungunya arthritis probably might have articular symptoms for quite a long time. Again, there is this condition called polymyalgia rheumatica, which usually happens in elderly population more than 50 years of age. Arthritis, enteropathic arthritis, subtypes of spondyloarthritis, they can present as polyarthritis or multiple joint pains. Acute sarcoidosis, in fact, is one of the rare causes, but they can present similar to rheumatoid arthritis, especially if they have erythema nodosum. One has to consider this possibility. And all the connective tissue disorders, including SLE, Sjogren's syndrome, and systemic sclerosis, one has to consider before labeling as rheumatoid arthritis. Well, it is quite prudent to classify patients presenting with multiple joint pains in one of the syndromes, whether patient has classical articular syndrome, that is his or her joint symptoms are specifically, they have myalgias and associated muscle tenderness to point towards muscle syndrome. And this about, even if you feel like patient has all widespread diffuse pain and probably just fibromyalgia, don't do that. Also, like autoimmune disorders, and one should adequately weigh sensitivity and specificity of various tests. Say, for example, rheumatoid factor, it has a sensitivity of around 70%. What that indicates is there will be 30% of patients with actual rheumatoid arthritis who will have negative rheumatoid factor. And if we consider other way around, the specificity is around 68%. So not all patients with polyarthritis who do have rheumatoid factor are rheumatoid arthritis. So there are many conditions wherein rheumatoid factor will be positive, say like in SLE, JIA, Sjogren syndrome. In fact, 70% of the patients with Sjogren syndrome will have rheumatoid factor positive. Even the IPF, which is usually managed by chest physicians, hepatitis B, cryoglobulinemia, bacterial endocarditis. This is one of the disease which many of us tend to uh, miss. Usually can present with articular symptoms and systemic symptoms. Even infections like leprosy, tuberculosis, and other mycobacterial infections. Leukemia, especially if young patients, one should definitely consider systemic sclerosis. So this is my last slide, wherein my and when labeling rheumatological possibilities that need to rule out. A number of investigations, diagnosticians. Rheumatologists, my dear friends, are very friendly people. Please consider seeking their opinion in case you are considering inflammatory arthritis. We are always very happy to help. Thank you for your patience listening, and it was a pleasure.
Well, starting first with Dr. Nilesh to
Multiple joint. So whenever patient comes with similar complaints, polyarticular pains, if it is less than stiffness, if the joints are stiff for more than 30 minutes, you can say that this is inflammatory arthritis, and you really need treatments. Usually causes a lot of problems. So it is always a specialist in a loop. So it's a multidisciplinary. Are recommended. Many times patients have never done any sort of tests.
Yes.
So routine tests, one tree is quite convincing of viral polyarthritis. Just the basic tests, I think, should suffice.
Specialist on the panel, and I request him to give his perception.
Why one needs to ask is there is a condition called enteropathic arthritis. Patients might have episodic diarrheas which they leaks. Patients will develop. Sir, to direct questions to the panelists also. They are esteemed experts.
Yeah, but I now for telemedicine, where the patient's blood can be sent to the
frequent. So in the early part, we might need it frequently, maybe 4 weekly or 8 weekly or 12 weekly. But eventually, telemedicine, even if patients cannot come, and just by history taking and whatever inspectory.
I would like to add one point here about telemedicine. Yeah, it's definitely a boon. It is definitely a beneficial thing for everyone, especially the people.
Perspective, that is one of the safest drug we have. Okay, and even with all advanced medicines, we tend to continue that. It's around 10 to 20% of the patients who are intolerant to that, basically because of nausea or GI side effects. Otherwise, in rest of the patients, it goes on very well. Only thing, the problem with it is once weekly. If it is taken daily, it can have devastating complications. So that is one thing which has to be clearly mentioned. So once weekly, it is very safe drug, and it's not a very strong immunosuppressant. There are other drugs which are very strong immunosuppressants. This is more of a disease modifying drug, and it forms the basic framework of treatment of most of the rheumatic diseases. And even initially, after initial this thing, usually 3 to 4 monthly or 3 monthly routine investigations usually suffice. Okay. Anything,
Wonderful.
Gayatri, you want to add, or Nilesh?
Yes, sir.
Dr. Shintri wants to say something.
Yeah.
Yes, sir.
Yes, sir.
Hello. Can I talk? Yeah.
Yeah.
Yeah, actually, as I understand, biologics, if the patient is needing, then in that case, the rheumatologist reference has to be there. Orthopedic surgeon should not try out that.
So, yes, so I would like to answer this question. Not only biologicals, even the demands. Yeah, because there are certain side effects of the demands which are to be monitored. Yes, and see, the delay in the means initiating the treatment is also important. Sometimes the dose of the methotrexate is given very small dose, or DMARDs are not given adequately. And so some doctors, some primary care physicians, they keep giving steroids for longer time. So when they see the patient, they think that patient is recovering, but at the same time, the joints are getting deformed. So the delay in rheumatology referral, it caused at the the joint gets damaged, or there are certain other extra-articular features which start developing. So initial immediate referral to a rheumatologist is very important.
I'd like to ask the rheumatologist that do you have any scoring systems for joint functions that you're using routinely to find out how much the patient, how bad the patient was at baseline and how much he's doing better? And also, at what point do you want to refer him to a orthopedic surgeon to explore if any surgical remedy could be found for his increasing deformity?
Okay. May I take this question, sir?
Sure, sure.
Yeah. So yes, sir. Thank you for the question. Actually, for rheumatoid arthritis, we have something called as DAS28, which is called as Disease Activity Scoring System of total 28 joints, which excludes distal interphalangeal joints and ankle joints and feet joint. And obviously hip and shoulder synovitis we cannot see, so we exclude that also. So it is quite useful because it comprises patient global, physician global, then the inflammatory markers, which are easily available. And then if baseline score is high and if patient comes to us on follow-up and if the score is decreasing, it is quite reassuring. Or it could be vice versa, if patient has had a remittive score and now the score is more. So we can just think about increasing the DMARD or giving extra additional steroid, etc. But the fallacy is a lot depends on patient global assessment and inflammatory markers. So sometimes our patients can have secondary fibromyalgia, or they could have had some recent infections. So because of that, ESR CRP could be high. But otherwise, it's a very good score. There are certain other indices like CDI or SDI, which are a clinical disease activity index, which does not require any CRP or ESR. Then patients have secondary knee osteoarthritis. When I know that my patient is in remission, trying my
Rheumatoid.
Behind. Maybe there are some surgeries or indications which are more justified nowadays.
I think the lower limb arthroplasty will be of great help. Thank you.
There are some tendon transfers, and especially with tendon rupture cases of the hands, which are very helpful if done in time. I think even there, what happens many times is our patients, we fail to recognize these surgical indications. So even rheumatologists have to be sensitized with certain indications, surgical indications by our orthopedic friends. And I would recommend or I would request Borate sir and even our organizers, Rahul and Dr. Ashok, to in future talks will involve hand surgeons.
Yeah, see, what I have found is that we tend to have a slightly biased perspective of uh, orthopedics being helpful only in where joints need to be replaced. I have seen, for example, a few patients who had restriction of, say, pronation supination, where the surgeon just did an excision of the head of the radius, and the patient was restored. The mobility that he wanted or was missing was restored. So it wasn't always that a joint had to be replaced or reconstituted, because the pathology is somehow not in our hands. Even with medicines, we have a certain amount of fluctuations that we cannot predict. Whereas operations like excisions sometimes may avoid the loss of the potential danger of infection and the potential high expectations that one generates when one expects a joint to be replaced. As you have rightly said, in the case of the knee and the hip, the results have been very, very outstanding and dramatical and also very consistent. Uh, I'm sure that the need for these replacements in the hand and the foot do exist, but the role is a little more limited and perhaps narrow, and that's why we find less of it being done, at least in uh, the practice that we see in the Indian situation. I hope, as you said, we can collaborate more, and especially where the rheumatologist feels that a little movement or restoration of movement is very important to the patient because he's dealing with the patient all the time and he's listening to the patient's problems. As long as the drugs are helping to maintain or retain that mobility that the patient wants, fine. But at some point when that starts going, that's the point where one should consider whether something surgical, including a replacement, maybe if deformity is progressing too much, maybe a judicious fusion and maybe sometimes an excision might just give the word back to the patient what he wants for a few more years. I think we are coming to the final part of this webinar. I'd request Dr. Shindre to give his views as we wrap up this webinar on where he thinks uh, orthopedic surgery has a bigger role to play in the management of patients of rheumatoid arthritis and other arthropathies.
Actually, in the past, we had seen many of such release surgeries, then excision arthroplasty of hand and wrist, also wrist fusion of wrist. But nowadays we hardly see them, or the number is quite less. Might be because the disease modifying agent has done wonders, and so people are really happy. Those who are having a swollen joint of metacarpophalangeal joints or wrist, they come to almost normal with methotrexate or other disease modifying agent. So that might be the cause of reducing the surgeries nowadays. And of course, the surgeries are not that safe also in rheumatoid because of many factors. Maybe osteoporosis, maybe more proneness for infection, and even the total knee replacement also. We are always afraid that whether the patient will do well.
Yeah, I'd like Gayatri to tell us about how we can educate the orthopedic fraternity more about the benefits of the treatment and the newer medications that have made the rheumatologists the center and the orthopedic more and more So we can
Internist, it's a common problem that people feel that we are just joint specialists. It is not so. A simple rheumatoid arthritis patient